Welcome everyone to today's program. My name is Emily Rapley and I'm a writer with Becker's Healthcare. Today's program will begin with a presentation and we will have a question and answer session at the end. You can submit any questions you may have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have, and will follow up on questions they do not have the opportunity to address. About a week after the webinar, you will receive an email that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after the completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Alyssa Dahl is a principal analyst for the DataGen Group. She began working in healthcare quality and payment policy several years ago as the DataGen Group expanded its analytic support to hospitals and health systems for healthcare reform. Alyssa conducts research and develops analyses around emerging payment models, comparative efficiency and care patterns, and is well-versed in measurements of quality of care for institutional healthcare providers. Prior to joining DataGen, Alyssa interned at the New York State Department of Health in the Office of Health Systems Management on Certificate of Need redesign and in the Legal Affairs Division on plaintiff enrollment into the Medical Indemnity Fund. Gloria Kupferman is the Vice President and Chief of Healthcare Data Analytics at DataGen. Ms. Kupferman has over 30 years of experience in health economics, healthcare finance, and data modeling. Ms. Kupferman has analyzed and modeled numerous hospital reimbursement alternatives, conducted extensive research and analysis on hospital market basket indices, and developed a series of reports and analyses on HMO finances and premiums. Ms. Kupferman is a nationally recognized expert and speaker on hospital financial and quality issues, such as value-based purchasing, readmissions, bundled payments, and the Affordable Care Act. Kelly Price is a senior director of the DataGen Group. Ms. Price has been working in healthcare finance for over 20 years, starting with the NYS Department of Health, where she developed managed care rates for the Medicaid program. For the last 17 years, Kelly has helped the members of the Healthcare Association of New York State understand changes in Medicare's reimbursement systems. As Senior Director of the DataGen Group, a subsidiary of the Healthcare Association of New York State, she works with hospital associations in 45 other states on Medicare and Medicaid reimbursement issues. Most recently, Kelly has been focused on providing decision support and education to hospitals and health systems across the country as they prepare for health reform payment strategies, including shared savings and readmissions. Ms. Price's team is currently providing data analytics support to over 40 awardees of the CMMI Bundled Payments for Care Improvement demonstration, including the AAMC convened group and the national nursing facility provider, Genesis Healthcare. It is now my pleasure to turn over the floor to Gloria Kupferman to begin today's presentation.
Thank you very much, and welcome everybody. I see we have a very large group of attendees, so obviously this is an issue that is of interest to everybody. We're going to spend today talking about the Medicare Mandatory Comprehensive Care for Joint Replacement, or CCJR program, but we're going to talk about it from the perspective of post-acute care providers. So that is definitely a different point of view, but an important point of view for those of you who are involved in the post-acute care setting. I've already been introduced, as have Kelly and Alyssa. We all work here at DataGen, which is a subsidiary of the Healthcare Association of New York State, and we've had the unique privilege and opportunity to work with a number of providers, both inpatient acute and post-acute, in bundled payment arrangements under the Medicare BPCI program, as well as other new payment reform and redesign programs. And we are going to share with you our experiences and observances over the past few years as we have worked with data in the other Medicare bundled payment program, the voluntary BPCI program, and what we've learned from that, and share our perspective on what the data show and how the data can be used to assist post-acute care providers in proving or understanding their value in this new payment model. So with that as my introduction, I'm going to turn it over to Kelly Price, and she's going to take you through the 7 things every post-acute care provider should know about the Medicare CCJR program.
Can we switch to the next slide, please? Thanks, Gloria. I'm not going to spend tremendous time on all of the details of the CCJR because I think a lot of people have already heard those ad nauseum, but I am going to cover a couple of basics in addition to what's on the slide. First of all, the CCJR program is DRG based, so patients land in the CCJR program if they are part of the 2 DRGs that go into lower extremity joint replacement, DRGs 469 and 470. And I say that because post-acute providers don't tend to think in terms of DRGs. You think in terms of diagnoses, groups of patients. Are they orthopedic? Are they respiratory? Much different types of groupings. And because DRGs have been a particular challenge to the post-acute providers that are involved in the Medicare bundle payments for care improvement program. So any patient that's in those 2 DRGs, this is not a diagnosis or procedure indexed program. What goes into the CCJR target and spend, the comparison, are all Medicare Part A and Part B spends for all types of services with very few exceptions. All skilled nursing, all home health, all inpatient rehab, all readmissions, Part B services. The only exclusions are things such as being hit by a bus, for example, or coming down with cancer or getting a heart transplant. There are some big exclusions there, but in general, everything is included in these bundles. The hospitals are the owners of the episodes and are fully responsible for the financial outcomes. What that means is that total spend for each 90-day episode of care, total Medicare spend, will be added up at the end of the 90-day period and compared to a target of sorts. That target initially is going to be a blend of the hospital's own history of spend over a period of time, but is rapidly going to move to a regional target. So hospitals are going to be forced to drive costs down to meet the averages in the rest of their region. The program is mandatory, as we've said, so hospitals cannot opt out. If they are in the MSAs that are chosen, they will be forced to either get used to the CCJR program or discontinue doing major joint replacements. And that will be actually a question for some of their lower volume hospitals out there. Patients cannot opt out. They can opt out of the data sharing portion of this and indicate that they do not want their data shared with the hospital, but the only way a patient can opt out of being part of the CCJR program entirely is to go to a hospital that is not involved in the CCJR program. That's kind of a new thing, I think, for Medicare. And of course, post-acute providers can't opt out. If you take a patient that comes from a hospital who's part of the CCJR, then you, in effect, are also part of the program. You're not financially responsible automatically, but you are part of that hospital, the spend that that hospital is going to be responsible for. And that's why you're on this call today. As I said before, episodes 90 days post-inpatient discharge. So once the patient is discharged from the hospital, going 90 days out, that's a very long period of time. I think hospitals' first reaction upon seeing the CCJR rule was shock that CMS was going to propose such a long episode for their first foray into a mandatory program. Hospitals can gain share and loss share with providers that are downstream from them in these bundles. They are not required to do so, but it is one of the primary incentives that is kind of newly available to hospitals to help influence the care downstream from them. Can we take the next slide, please? Thank you. So how does this affect you? You're downstream from the episode owners, which means that all of the hospitals are going to be looking to you to figure out what's the most efficient way to provide care and helping them to meet their targets. You are not going to receive any data on what's going on with the CCJR the beneficiaries that are part of the CCJR program that might be your patients. You won't necessarily know who they are unless you have a close relationship with the hospital. CMS is not going to provide you data on the patients that you see that are part of CCJR. This next one is very important. Post-acute providers don't typically think about value in terms of cost effectiveness, and frankly, the concept is downright offensive to many providers for lots of good reasons. However, this is what's going to happen in this program is because of lots of reasons, some of which Alyssa is going to discuss later. Efficiency and high value care is going to be measured in dollars and cents in the dollars that are spent on a patient. So that's kind of a stunner to a lot of folks. And so because you're downstream from the episode providers, because comparison to target is going to be based on dollars, you have the most at stake here in terms of your volumes, your referrals, and your business going forward. Next slide, please. I'm going to go through a couple of visualizations that reflect how the hospitals are going to be looking at the data that they're going to receive from CMS on the spend for patients that are part of the CCJR. The visualizations that you're looking at come from data that we purchased from CMS, the Medicare 100% standard analytic files. So we are able to look at the spend for all episodes of care in the historic periods that CMS is going to be using for the targets. Let me explain what the charts are that you're looking at. The bigger chart, each of the vertical bars is a single 90-day episode of care, and the different colors within those bars represent the different settings of care. So the dark blue at the very bottom is the CMS spend for the anchor admission. The green is the CMS spend for skilled nursing facility care. The bright blue is inpatient rehab, the yellow is home health, and the red are acute readmissions. The smaller chart in the upper left of that larger chart, instead of being one bar per 90-day episode of care, they are the average for certain groups. So the bar on the far left is the average spend broken down into these categories for all of the episodes of care that a single hospital sees. So essentially, the larger graph rolled all up into one so you can see the average. The middle bar is the average spend broken down into the care setting categories for the census region, which at the moment is the way that CMS is proposing to set targets, a blend of hospital historic performance and regional, and moving towards that census region. And the far right bar is the US average broken down into the spend categories. So what you can see in that smaller graph is that for the particular hospital that we're focused on in this slide, the average spend for all of their episodes is considerably higher than the average spend in the region. It's also considerably higher than the average spend in the US. You can also tell by looking at that overall average bar that the real difference, the driver of that higher spend, is the green section. And that's an indicator of high skilled nursing facility utilization. So this particular provider is going to want to look very carefully into their individual episodes and see why their SNF spend is so much higher than the region and the US, and decide what they're going to do about it. Part of the looking at that in detail is to look at the individual bars that we're seeing. And what you can tell immediately by looking at those individual bars is that the high SNF spend isn't due to just one or two cases with a really long SNF length of stay and a very high SNF spend. There is SNF care involved in about 90% of the episodes in this chart. So that's an indicator that just about everybody's being sent to SNF. So the next thing that the hospitals are going to need to do is figure out why so many patients are going to SNF and whether it's appropriate. And frankly, one of the things that you can't tell from the data in these charts is exactly why those patterns look the way they do. We always like to say that the data is the beginning of the conversation. We try to provide visualizations of data to help the teams of care providers and care coordinators start their conversations using easy to digest information. So those care coordinators in the hospital are going to need to figure out how are folks getting referred to SNF? I mean, what is the process in their particular hospitals for referring to SNF? Are there other ways to do things? Can a patient go home? Do they have the social supports at home in order to be able to go home and perhaps receive home health care instead of a more intensive institutional setting? So that's an example using a hospital that's got a particularly high skilled nursing utilization. And the next thing to be thinking about while you're looking at this graph, sorry, thanks for staying on this slide, is to notice that, and this is the main point of this entire graph, all of the variation in spend, with very little exception, is in the post-acute setting. That very bottom part of the bar, the dark blue, the anchor admission, because this is a DRG-based bundle, every single anchor admission costs CMS the same amount of money. So while the hospital might be able to increase their margin under that single DRG payment, they can streamline the implants that they're using, they can incentivize their physicians to spend less time in the OR. None of those things impact the spend from CMS's point of view. The only thing, and therefore, none of those changes in the inpatient setting are going to influence the comparison at the end of the day to the target. All of the reduction in spend that hospitals are going to be driving towards is going to have to come out of those post-acute settings. So next slide, please. This is, and by the way, the graph you were just looking at is a real hospital. Each of the graphs that we're going to show you are real examples of data. None of this is made up. This particular slide is an example of a hospital that also is significantly higher than the region in the U.S. That's the little embedded small graph in the upper left. And you can see immediately that the driver of that increased spend compared to the region in the U.S. is the bright blue, which is inpatient rehab. So again, you have to drill down into that. Is that a couple of patients? Is that a preponderance of patients going to inpatient rehab? And in this particular picture, just about every single patient is being sent to inpatient rehab, with the exception of a handful of cases that are going to skilled nursing. And we've seen this kind of pattern. We've even talked to a couple of the hospitals that display this kind of pattern. We have an interesting example of a hospital who has inpatient rehab facilities in their own network, but the inpatient rehab that their patients are ending up going to is not even part of their network. So that's part of the downstream look at the data as well. When you're looking at that inpatient rehab spend or the skilled nursing facility spend, in addition to how are my patients getting there and can they go somewhere else, another one of the questions is this their own inpatient rehab facility? Do they own this, and therefore by changing a pattern, are they going to be eating into their own revenue? And so that provides some different incentives. If you're part of a system, there may be a discussion around shifting resources from one part of the system to another. But this is an example of high inpatient rehab facility utilization. And can we go to the next slide, please? This is what I call my ideal graph. Okay, ideal from the perspective of a hospital that is trying to succeed in a bundled payment program. And this, again, is going to be very important for you to understand. What you're seeing here is an overall hospital average in the small graph embedded inside that is significantly lower than the region in the U.S. So this is a hospital that if they can figure out how they got the distribution that they did, how they got the spend that they did, is going to want to make sure that they understand how they got that spend and can they keep it that way, because as the program moves to a regional average, they're going to do particularly well compared to that target. What you can see in the bigger graph that is 1 bar per 90-day episode of care, is a real distribution, a real shift across from the least expensive episodes on the left-hand side, and about 10% of which are using no institutional post-acute care whatsoever, just outpatient physician and some outpatient hospital. And then a group of episodes that are just receiving maybe a couple of days of SNF care and some home health. Then a bunch more towards the middle of the graph, you start to see the higher intensity spend on patients. Another thing I like to say is that while we hear a lot in the news about the unexplained variation in spend, in a case like this, in a program like this, where you're grouping patients by DRG, and you have lots of different types of patients that go into that, you have hip fractures, you have knee replacements, you have ankle replacements. Here's a place where you want to see variation. You want to see variation because it indicates that that the hospital provider is looking at each patient as an individual, assessing their condition, assessing their home supports, has good availability in the community of varying types of post-acute providers. They have home health, they have access to home health, they have access to rehab, they have access to SNF, and can make individual level decisions about where a provider should go, which provider a beneficiary should go to. So can we have the next slide, please? And at this point, I'm going to turn it over to Alyssa to discuss quality measures.
Thank you, Kelly. The first point I'm going to hit on is about our quality measures and outcome measures and how measures that are more meaningful currently don't exist. The CCJR program has 3 quality metrics as part of the program. They're your hip and knee readmissions, complications, and patient satisfaction as measured by HCAHPS scores. However, there are some problems with these measures worth mentioning, among others that I won't mention. The measures are lagged and blended across multiple years. The measures don't measure patient outcomes after leaving the care setting, and they also don't measure a patient's function either. In the case of these episodes, they are measurements of extreme outcomes only. What is really needed in a program is a way to measure a patient's function and ability to return back to their daily activities after the episode has ended. These types of meaningful measures don't exist yet, so we all have a pretty good idea of what they would be. The number of days it takes a patient to gain full recovery, patient satisfaction across the entire episode, and not just during the acute admission that was part of their surgery. And as I've mentioned earlier, activities of daily living. How independent are patients living after the end of their episode? So what does a post-acute care provider do now in the meantime? Right now, the only quality areas that CMS is looking at in the post-acute care for the post-acute care provider to influence are readmissions and complications. Hospitals are going to be looking at downstream providers to prove their value by showing their readmission and complication rates are lower than others. Post-acute care providers need to develop trusting relationships with their referring providers. There is opportunity available. You can drive down your readmission and complication rates in exchange for a preferred provider status or even a share in those cost savings. What else can post-acute care providers do? Start collecting these more meaningful measures of patient outcome after the end of an episode. Discuss how you might change some of the patterns that you're already seeing in your own data. We know post-acute care providers already have a pretty good idea of how their patients do in the end, but having data on this is the key to actually showing your success. While there is no national standard yet, providers who track these measures will be prepared for when a standard is introduced. Next slide, please. In addition to being an important metric in measuring the quality of the episode, readmissions are important to touch on, and the readmissions are really what we see driving the spend in an episode. Here we can see the impact on the average spend. If you look at the chart on the top, we've broken out episodes into where the patient goes first following their surgery, what post-acute care setting that is, and whether these are episodes where there was a readmission or there wasn't a readmission. So the real startling thing to see here is when a patient in, for example, that goes to self-care first or the home health setting first, for episodes where a readmission occurred versus episodes where a readmission didn't occur, there's a difference in spend by about $10,000. This difference is then exacerbated for patients who are going to a SNF first or going to an inpatient rehabilitation facility first, where there's a difference in average episode spend by about $20,000. In the episodes where readmissions do occur, we see an extension also in the amount of post-acute care that's being spent. This is likely because the therapy for a patient is put on hold during the readmission and then must be restarted again from the beginning when the patient returns to the post-acute care setting. If you look in the bottom corner, we've also displayed the top 10 reasons for readmission in major joint episodes. These 10 reasons that are listed by their DRG account for 25% of all of the readmissions observed in these episodes nationally. You can see when you read some of these names off the table, cellulitis, UTIs, many of these reasons are for infections, and some of these reasons are also for revisions and orthopedic-related issues. So here's something for post-acute care providers to think about. Which of these readmissions might you have been able to prevent? Revisions are likely out of your control. But what about the urinary tract infections showing up on this list? How do you view some of these conditions? If staff could give IV antibiotics to a patient, would this perhaps prevent the observed readmissions? It is essential that post-acute care providers review their data and know why are their patients being readmitted and how soon into the post-acute care stay are patients being readmitted. Post-acute care providers can also demonstrate their value by showing what they are doing or plan to be doing in their care setting to reduce post-operative infections and other complications. Next slide, please. Next, we're going to talk about inpatient rehabilitation facilities and how we found them to be the most expensive post-acute care setting. And this is really because of two reasons. First of all, we see inpatient rehabilitation stays. They generally cost a couple of $1,000 more than, for example, the skilled nursing facility component of an episode where the patient first goes to a skilled nursing facility. Secondarily, we also see that some inpatient rehabilitation patients still step down to a skilled nursing facility and home health care after their stay. They continue to use more types of post-acute care after they are finished in the inpatient rehabilitation setting and are using more than what we see in other episodes. Without meaningful patient outcome measures that can be monetized, how are inpatient rehabilitation facilities able to justify this amount of higher spending? Perhaps in the short term, are inpatient rehabilitation facilities in a better position to transform care or to reduce readmissions and complications? In BPCI, we have heard of several strategies targeted at this question. A hospital can keep a patient a few days longer during the stay and then discharge patients to a lower intensity care setting. Taking this strategy into the perspective of an inpatient rehabilitation facility, the rehab could then take the patient for an extra couple of days at no cost to CMS and avoid sending their patient to another step-down setting after their stay. We know the disadvantage here is that it would slightly eat into a rehab facility's margin. However, the rehab does have a value proposition that they can show in this example and a way to encourage the hospital to share savings, finding an advantage after all. Next slide, please. And what else helps drives cost of care? We also see the length of stay in skilled nursing facilities. We know that there are two drivers of the cost of care when we're looking at skilled nursing facilities. One is the case mix, which we don't really have any control over, and the other is the length of stay. So when we're looking at this chart, on the bottom you'll see each bar represents episodes depending on the number of days that they spent inside of a SNF. And we see that the amount that's being spent in these episodes is increasing from the left to the right incrementally with each day in the SNF, exactly how we would expect it. But what we're also seeing a correlation with the red dots shown across the graph is the readmission rate also steadily increasing with every day a patient spends in the SNF. Skilled nursing facility reimbursement, as we said, is on a per diem basis, so we're incrementally increasing that cost of care. but the readmission rates, this is likely driven by also the health status of the patient and also more days at risk in the SNF for complications. Skilled nursing facilities need to start thinking creatively in their care plans, and this brings us to our next point. Next slide.
So the advantage and the interesting opportunity that a bundled payment arrangement provides is that money is fungible. And so you can consider doing creative things that you may not have been able to drop a bill for before. But if they can create savings and you can be part of the gain sharing of those savings, it may be worth your while to consider these alternatives, even though you can't drop a bill and you won't actually directly be paid for them, because they will generate savings, such as some of the things that we're hearing from post-acute care providers that we're working with is putting together a team, especially when you're talking about major joint replacements, a team that will meet with the patient prior to their surgery to set expectations as to what their follow-on care will be, that they will go home or that they will only spend a limited amount of time in a skilled nursing or rehabilitative setting, that they make sure that they have all of the supports possible in place, or if the supports aren't there, that screening identifies them, and then those supports can be provided. Now, granted, the Medicare program doesn't pay for Meals on Wheels or home delivery of meals or for transportation to doctor's appointments or to outpatient rehab. But if the provision of those services could drive significant savings, it might behoove either the acute care provider or the post-acute care provider to start providing those types of soft services in exchange for the higher intensity, higher spend stay, so long as there is an agreement to share in the savings so that your investments are recouped. Similarly, we're hearing from a number of inpatient acute facilities about keeping patients a little longer in that acute care setting so as to start the rehab while the patient is in that acute stay, and then they can go home as opposed to a step-down post-acute setting. Because remember what Kelly showed you in that earlier slide, the DRG payment stays the same. There's been tremendous pressure on hospitals with the DRG payments to reduce length of stay to improve their margin under that DRG payment, but now the incentive might actually be reversed, and we're hearing some success stories with extending the stay for an extra day to get that patient much more acclimatized, walking around, etc., so that they can go home. Certainly this opens the door for use of telehealth in a more meaningful way. If a barrier to going home is, fear of falling or being in touch with a caregiver, telehealth can be a way to give somebody more comfort in going home. Utilizing more home health care is the go-to answer. Think about the graph again that Kelly showed you, or the graphs that Alyssa showed you. The yellow is always the smallest piece of the spend. Home health is a far less expensive post-acute care setting because it's not residential. You're only paying for that care. However, there is a barrier there in that the bandwidth of home health providers is not infinite. And so there might be some opportunities for post-acute care providers that were not providing home health services before to think about some creative ways to follow patients up in their homes, and that's that last bullet there. There are a lot of interesting and new ways to approach helping people get home sooner, which is what everybody wants, including the patient usually, because everybody gets better faster in their own home if they had the additional supports. So coming up with some of these non-conventional strategies that you don't usually drop a bill for, you don't usually get paid for, but now the payment would be in the shared savings. The key is shared savings. There is no incentive for a post-acute care provider to do any of this unless they get a share of the savings from the episode owner. Next slide, please.
And our last imparting wisdom for post-acute care providers is that you need to know your value. So in this graphic that we have here, we're displaying a number of different skilled nursing facilities. They actually happen to all be located within the same referral region, and they draw their patient population from the same group of referring acute care providers. From looking at this chart, we can see that every provider has a story. Some of these providers have much higher spend when you look at the amount of skilled nursing care that you're using. Maybe in the case of these providers, they're giving and providing higher intensity care to their patients, which could be why their story is slightly different than in others. Some of these providers have more money going towards readmissions than others. In some of these cases, you could also see costs could look very similar, but maybe there's something in here that could give your post-acute care facility an advantage over the next setting, such as reducing that readmission rate or keeping your patients a day or two less. You really need to know what your strengths are and what your weaknesses are. If you happen to be a low-cost provider, then you'll already stand out immediately in the selection of a downstream provider for an episode. But if you're a high-cost provider, the post-acute care provider really needs to know why. And as I said, it could be for a couple of reasons, such as treating patients at a higher intensity level, and then you should be producing better outcomes because of what you're doing anyway. Or if you do see that your facility has a real problem, this is your opportunity to rectify it. This strategy could be used to address your care problem, and you could also use it as a strength in negotiating your ties to a referring provider by addressing those issues. These 7 things will prepare post-acute care providers for when CCJR becomes a reality.
So next slide has, well, we'll take questions now. We have a number of questions queued up, and I'm hoping that more people will submit questions as we move forward. We try to leave plenty of time for questions because I'm sure for some of you this may be the first time you're looking at this information this way. So Emily, if you want to start sharing questions with us, we'll be happy to take them on.
Sure, thank you. Gloria, Kelly, and Alyssa, that was a very informative and enjoyable presentation. So as we mentioned, we will now begin the Q&A portion of the program. A quick reminder to our audience, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. We'll have Gloria, Kelly, and Alyssa attempt to answer as many questions as they can in the about 20 minutes or so we have left, and they will follow up on any questions they do not have the opportunity to address. So we have quite a few questions flowing in here. The first one from our audience is, would like to clarify, for CCJR, hospitals are considered episode initiators, and physicians and providers do not have the option to be an episode awardee. Is that correct?
That is correct. It is hospitals only. It is meant to be a true pilot program where the episodes are owned by the hospitals. If CMS were to allow physicians to be owned, there would be too much overlap and too much open for gamesmanship. The BPCI program is a voluntary program that did allow either physicians or hospitals or post-acute care providers to be the owners of the episodes. But that program is already in progress and is not open to new entrants at this point.
One of the questions we think that CMS is considering when they decide who the episode owner is the capitalization. And I think they're going to be looking over time at what kinds of episodes would be more appropriate for the physician to be the episode owners of. And part of the consideration is going to have to be, does a physician, an individual physician, have the financial backing to be able to withstand an episode that's an average of $25,000?
Wonderful, thank you. So for our next question from the audience, how would a post-acute facility find the CMS data at which the hospitals are looking? Specifically looking for RTH, ALOS, number of referrals and admissions, and cost per patient.
We've actually been getting this question increasingly more regularly, and which is one of the reasons that we're doing this webinar. An individual provider can purchase the data from CMS that goes into what we've been showing you. You can go through the DUA process, the data use agreement process, purchase the data, and take a look at this yourself. Or we have developed models that look specifically from the post-acute provider perspective, give you a picture of who are the referring providers, who are the hospitals that are referring to you, what other providers are those same hospitals referring to, and how do you stack up dollar-wise readmissions, length of stay. So that's something we can certainly discuss with you if you'd like us to.
Wonderful, thank you. So another audience member wrote in, it is my understanding that to make the CCJR initiative work, CMS will allow acute care providers to determine that the PAC providers that they want to partner with. This, in effect, removes the patient the right to choose their PAC provider. Is this still the way the program is structured?
It's not quite. It's the hospitals can decide who they wish to gain share and loss share with. And hospitals can certainly provide information to patients on, nationally available quality metrics in terms of this is the readmission rate for this particular SNF compared to that particular SNF. Hospitals have no more control, though, over where the beneficiary goes than they ever have. They still cannot steer patients. Beneficiaries still have the final say. It will simply be that hospitals may be providing information on the quality of care from certain perspectives that's provided in this facility versus that facility. You still can't steer patients.
Can't steer patients in the governmental programs, but certainly, just like there are preferred providers in skinny networks now, certainly there will be a list of preferred providers. So from a post-acute provider standpoint, and I think that's the point of our last slide, to know your own value is extremely important. And there's always a story to tell. If you can look at your data and know that the patients that come to you end up having best outcomes and low spend, and you know that, then you should be bringing that value proposition to the upstream providers and working to arrive at some metric or some opportunity to share in whatever savings are generated by having you as part of the preferred network. On the other hand, if you are a post-acute care provider and you see that regardless of the outcomes, and they still may be stellar, your patients that are seen in your setting tend to be a higher spend, then you need to evaluate whether or not your value proposition is that you provide higher quality and the higher spend is justified, which is going to be tough in a model like this. Or you need to perhaps admit that you have some ballast that can be thrown overboard and negotiate some sort of a guarantee with the upstream providers to create the savings and be part of the preferred network because you make a commitment to make that change.
Sure, that makes a lot of sense. Okay, so for our next question, we have an audience member who would like to know a little more about, for post-acute, for the medical equipment that home health does not have, how that's impacted.
Durable medical equipment is included in the spend of the CCJR episodes. And I believe that's the answer to your question.
Okay, wonderful, thank you. So for our next question, has Medicare looked at the age and comorbidities of patients who go to the SNF? This person's experience is that the sickest patients without family support go to SNFs post-joint replacement.
CMS, I have no idea what CMS has looked at. CMS has looked at dollars. CMS is very concerned with dollars. We've looked at, to the best of our ability, and our analytics, we look at length of stay, and we also look at cost per day, which is an indication of the RUG category in the SNF. What we have found, and this should surprise no one, with the lower major joints, is that the only real difference we see in spend and use of post-acute care and intensity is for patients that are getting a hip replacement because they had a fracture. Okay, those tend to be the oldest, most frail patients, highest spend. We have commented to CMS on this. We're waiting to see what comes out in the final rule. We are hopeful that CMS will have found our data to be compelling and will make some sort of a risk adjustment for those patients. Short of that, there is a undercurrent here, and I know I saw somewhere in the questions something about this too, in terms of the concept of rationing and making decisions about which patients would be good candidates for hip replacements, and if you know somebody is very frail, or compromised, do you do such a procedure on them to begin with? And I think that's going to be part of the conversation with the orthopedic surgeons, who truly are the ones who drive the decision making here. But it's very hard. There's not enough real information about the patients when you're looking only at claims to determine whether or not one patient was more likely or needing to be in a SNF setting versus another. And a lot of times it's really about frailty and ability to get around in their own home without social supports. So you're talking about being able to get to meals in the bathroom as opposed to a real medical need. And so that's where those non-conventional strategies might come into play.
Sure. Thank you. So for our next question, it seems use of more creative interventions are completely dependent upon critical volume of bundled payment people. Have you ratified this?
Well, I did mention a little bit at the beginning that hospitals who have particularly low volumes in major joint replacements are going to have to think very seriously about the financial risk of continuing, because one or two very high cost cases can cost a hospital a tremendous amount of money in terms of a percentage. Yes, volume is always a benefit when you're trying to change the way care is provided and develop creative strategies. However, we've certainly seen some of the smaller providers who are involved in the BPCI still be successful in terms of creative strategies. They may not be able to implement the ones that require more capital funding up front. So you're right. Volume is definitely beneficial when you're talking about creative strategies, but there are other ways.
Okay, thank you. Our next question, can you give examples of how savings get shared? How much and by what criteria?
That's the big question. And I mean, there are lots of different gain sharing strategies going on. CMS is providing just about zero guidance on what are acceptable gain sharing strategies. What we see in BPCI is that the episode owner needs to provide CMS with details of the methodology they are going to use, but CMS is not requiring a particular methodology. There are lots of different ways to do this. Overall savings, percentage of patients seen, percentage of dollars. What we do always see, though, are quality metrics tacked on, similar to the way that CMS is going to require a particular threshold of performance on the 3 quality metrics that they're proposing before savings can be shared. The same is true of these gain sharing arrangements, but they are about as varied as you can imagine. If you've seen one, you've seen one.
Okay, thank you. So how can our audience members find if this data is available to hospitals for SNFs in their area? Our audience member is coming from the San Francisco Bay Area.
I can't remember offhand whether or not San Francisco area is one of the mandatory MSAs. If it is not one of the mandatory MSAs, the only hospitals that are in one of the 75 mandatory MSAs and therefore mandated, deemed to be in this program, those are the only hospitals that will be getting claim level data across all the settings for their bundles. Hospitals outside of those mandatory areas, if they're not participating in one of these programs, they don't get this data automatically. They would have to go through the process that Kelly spoke of earlier. As a post-acute care provider, and I know there's been a number of questions on this as well, as a post-acute care provider, you do not have any avenue direct to CMS to get this data for the episodes that you participate in. You are either reliant upon the hospitals that you partner with to share the data that they get with you, which they can do if you ask nicely, or to find some other entity that is working with the data who can help you. DataGen, we can help you to some degree using our national data sets, but even if, like for example, all of this data is locked down for privacy security reasons under HIPAA, so it's not, it's claim level, patient level data. So even if we as DataGen were working with a hospital on a CCJR and your post-acute care provider was included in that data, we would not be able to share the data we received on behalf of that hospital with anybody else that works with their hospital, even the data that touched them, because the data use agreement is very explicit about sharing data. You must make CMS aware of everybody you're sharing that data with. So whereas it's an incredible opportunity to get this data, it's the first time that many providers have seen this a cross-setting type of data. It is still pretty locked down in the way it can be shared. So your best bet is to establish a relationship with those upstream providers so that they will share the data with you.
Okay, thank you. And we have about 5 minutes left, so we're going to try to fit as many questions as we can in the time we have remaining. But if your question does not get answered, remember our presenters will follow up on questions they have not addressed. So for our next question, an audience member said it makes sense that PACs would want to become preferred providers by proving their value. However, how much discretion does an inpatient provider really have when patients choose their PAC? Hospitals can't steer to specific PACs.
Again, this is true. Hospitals do not require that a patient go a particular place. What we see is that patients are generally listening to their physician, okay, unless they have other reasons to feel particularly strongly about something. But generally, they're going to have a good relationship with their physician. That's why they will have chosen the physician for at least the elective procedures. So if the physician is recommending to a patient that they see good outcomes when a patient goes to a particular post-acute provider compared to another one, patients are listening very hard to that kind of information. So patients can make their own decisions, absolutely, but the physicians and to a different degree, the hospitals themselves do have a significant amount of influence based on the information they can provide the patients.
Okay, thank you. So for our next question, when will the dollar targets be determined and how will they be communicated?
The targets, the final rule has to come out first, and the final rule is not out yet. We expect it very soon. We know that it's in review at the Office of Management and Budget. The program was supposed to start January 1, and CMS was saying at that point that the program would start on January 1, and targets and data would be coming out within a couple of months after the start of the program. So certainly a non-starter as far as the industry was concerned. What, you're going to make us participate in a program and achieve savings, but we don't know what our target is and we don't know where we are, so we can't tell where we need to go? I don't think so. So we are expecting now that the start date will be pushed back, mainly to catch up with when CMS can have the data available. It's a guess, but I would guess that the data would not be coming out any sooner than March, maybe later.
And we think that the targets will be available at the same time.
Okay, thank you. So can organizations not selected for CCJR get access to post-operative utilization data?
No, not unless they go through the DUA process with CMS, or reach out and spend money with some firm, a consulting firm like DataGen that might have the data.
But the real-time data, the more real-time data that the hospitals are going to receive, the post-acute providers have no access to that. And that may be an area that post-acute providers want to comment on the next time CMS publishes a rule.
I just saw a question come in. I want to take this one because I think it's important and we didn't mention it. There are some safe harbors being proposed similar to BPCI, and as it relates to post-acute care for skilled nursing facilities. Okay, similar to BPCI, CMS will waive the 3-day inpatient stay requirement that is usually required before Medicare will cover a skilled nursing rehab stay if the patient is discharged to a skilled nursing facility with a 3-star rating or higher. So the question was, will that be waived? It's no, that the 3-star rating is still going to be a very important rating as a SNF, especially if you are in one of those MSAs where you'll be downstream from a CCJR hospital, because whereas there's some thinking that maybe lengthening that acute care stay might be the way to go, if you could partner with the hospital and do a smooth handoff and do rehab and get the patient in the SNF and out of the SNF quickly, and you're a 3-star rated SNF, that might be a great value proposition.
Wonderful. Thank you, Gloria. Well, that is all the time we have for questions today. I want to thank all of our presenters, Gloria, Kelly, and Alyssa, for their excellent presentation, and for all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program. Have a wonderful afternoon.